Lastly, I will discuss how the surgery is performed. When planning the surgery, there are generally two main considerations. One is the approach method, whether to perform a thoracotomy or opt for minimally invasive surgery. The second aspect is determining how much of the lung to resect. In cases where minimal resection is needed, wedge resections are performed. With more extensive resection, segmentectomy is chosen, and for substantial removal, a lobectomy is performed. The left image is thoracotomy, and the right one is thoracoscopic surgery. There are many advantages to performing thoracoscopic surgery. First, it causes less pain, offers quicker recovery, and has fewer complications. Additionally, it helps prevent musculoskeletal deformities. The left image shows a patient who underwent thoracotomy surgery at a young age. As you can see in the picture, several skeletal abnormalities are observed. Rib fusion is detected, which occurs due to the practice of suturing and tying two ribs together during thoracotomy. Such rib imbalance can affect the spine, leading to scoliosis in this patient. These phenomena are commonly observed after thoracotomy. However, the patient on the right underwent thoracoscopic surgery, and no such phenomena are present. Therefore, to prevent these musculoskeletal abnormalities, it's evident that thoracoscopic surgery is highly advantageous. This study is a comparison between musculoskeletal abnormalities in thoracotomy and thoracoscopy. Thoracoscopy is reported to be superior in terms of chest asymmetry, nipple location, scoliosis, intercostal narrowing, and scar issues. Therefore, for young patients, it is recommended to avoid thoracotomy if possible and opt for surgery using thoracoscopy. So, it might seem like a simple solution to perform surgery using thoracoscopy for all cases. However, performing thoracoscopic surgery in such young patients is not as easy as it may sound. This is because there are many technically challenging situations. The reason for this is that the size of the lungs in children is very small, and the size of the vessels and bronchi that need to be dissected and resected is also very small. This graph illustrates the learning curve of my pediatric thoracoscopic lung surgeries. The horizontal axis represents the number of surgeries, and the vertical axis represents the duration of surgery. The graph shows the analysis of how many surgeries are needed for stabilization through the duration of surgery. In the initial surgeries, the procedure took around 5 to 6 hours. However, it becomes evident that over 50 surgeries are required to reach a stable state. Thus, surpassing this learning period is crucial. However, many surgeons often struggle to overcome this threshold and give up. Additionally, the rarity of the condition makes it challenging to accumulate experience in a short period of time. The most crucial individuals for successfully performing these challenging surgeries are pediatric anesthesiologists. The specialized tube system you see here has been created directly by the pediatric anesthesia team. They use neonatal bronchoscopy for guidance and employ techniques such as using a Fogarty catheter to block the main bronchus. In this way, pediatric anesthesiologists have been instrumental in assisting with early stage 1 lung ventilation in children. Next is the content regarding how much to resect. No matter how remarkable the lung regeneration capability is in children, it's better to resect as little as possible. Preserving more of the normal lung will be advantageous, especially for those expected to have a life expectancy of 100 years with advancements in medical care. This is because as they age, there could be various benefits in several aspects. Particularly in the current situation where periodic pandemics occur, it's conjectured that having good lung function might be more advantageous for survival. Therefore, the intention is to minimize lung resection, but there are several issues to consider. Is it technically feasible? Can it be completely removed without leaving any remnants? And in the long term, does it actually result in better lung function? From a technical perspective, lobectomy is already challenging due to its size, but segmentectomy presents an even higher level of technical difficulty. Segmentectomy is performed in two main scenarios. The first is when the lung lesion is truly small, and the second is when it's so large that it encroaches on two lobes, requiring the procedure to preserve the lung as much as possible. Since 2010, we have performed segmentectomy on approximately 85 patients at our hospital. This paper is a comparative study between segmentectomy and lobectomy, and it shows similar outcomes in the early stages. An interesting point is that while segmentectomy had a higher incidence of air leakage complications, overall complication rates did not significantly differ between the two groups. In other words, despite the technical complexity of segmentectomy, we can say that it yields early results similar to those of lobectomy. Furthermore, comparing the pulmonary function tests between these two patient groups, we observed that the reduction in FEV1 was proportional to the number of segments removed in the segmentectomy group. Additionally, when a smaller number of segments were removed, we observed less decrease in FEV1 compared to lobectomy. Therefore, while pediatric patients exhibit excellent lung regeneration capacity, it can be noted that preserving lung function is more advantageous by removing fewer lung segments. So, in conclusion, thoracoscopic surgery has many advantages in pediatric lung surgeries, and furthermore, preserving as much normal lung tissue as possible is advantageous for lung function preservation. Therefore, efforts are being made to perform surgeries of this kind more frequently. Thank you for your attention.